I think the session's a great follow-up. We'll try to live up to the spirit of what Dennis had to share. So as you know, the demands placed on healthcare workers have become increasingly intense. They're expected to deliver team-based coordinated care in complex and uncertain environments, including most recently the pandemic. Can't get much more complex and uncertain than that. At the same time, we recognize healthcare workers are a highly diverse workforce with large inequities that seem to be growing larger, reflecting growing inequalities in the larger economy. So it's kind of an interesting paradox, delivering highly coordinated team-based care with large inequities between members of that healthcare team. And then relatively little is known about how these working conditions affect worker outcomes. So this panel really seeks to address that question, to examine the relationship between organizational and structural features in healthcare and their effects on worker outcomes, such as mobility in this first presentation, economic outcomes, job stress and job satisfaction across this a highly diverse range of occupational groups that do work together to deliver patient care. So that is our context. And that only took 1 minute. So I think that gives us more time for the presentations and then our discussion afterwards. So here's how the session will be set up. We are going to hear from our presenters 5 minutes each. So relatively brief presentations is what we decided as a group. I'll introduce the first set of speakers in a moment. And then we'll turn it over to our discussants to talk about the implications of the findings that we'll be presenting. That would be Sara Chaganti, Federal Reserve Bank of Boston, and John August from Cornell University. And that should leave us a good 20 minutes for broader discussion across this group, which we're very much looking forward to. So please feel free to chat in the box as we're in the chat box as we present. Any questions that come to mind, we'll be monitoring those, and then and we'll have a chance to then speak those questions into the group after we hear from our discussants. So, all set. This is going to feel like a quick set of presentations. So take notes and look forward to talking together when we're done. Our first presenters are Jessica Santos and Sara Soroui from Brandeis University. And I think it will be Sara presenting today on behalf of the author team.
Yeah, so let me share my screen. Does everyone, Jody, do you see a PowerPoint?
Yes, we do.
Okay, perfect. Great. So thank you, everyone. This is a really exciting panel, and we really look forward to your feedback. So our team, led by Jessica, has been engaged in a research project that uses the analytical framework of intersectionality to understand occupational segmentation in the healthcare sector. And our research in this area is primarily policy-oriented, so our scholarship really fits within sort of an overall research and action agenda. And with this project, we're really interested in translating these findings to inform the design of equity-oriented career pathway models for both employers and public workforce development stakeholders. So Jessica and I are presenting really preliminary findings from the second phase of a larger study examining intersectional dimensions of segmentation in the healthcare labor market. And so in the first phase of the project, the team used ACS data to identify patterns of occupational segregation in the healthcare sector by interacting various identity pairs, including race and gender. And the findings really confirmed what's been found in other literature, which is really the overrepresentation of women and people of color in occupations with poor job quality, and also extends that research by demonstrating segmentation along intersectional lines. So this chart, for example, depicts the distribution of workers by race and gender in occupational categories that are classified according to, among other things, advancement and earning potentials. And so you can just look, I noted it with an arrow. For example, the secondary external distribution encompasses occupations with the lowest earning and advancement prospects. And from that, we can see really the overrepresentation of white women, Black women, and Hispanic men, relative to their overall representation in the healthcare sector. So In the second phase of this project, we wanted to understand how these patterns are reproduced and reinforced in the workplace. And while there is a substantial literature on the mechanisms of workplace bias and its effects on career mobility in general, much of it still uses a singular lens of social identity as opposed to the intersectional lens, which is really motivating our inquiry. So to give our sort of quantitative data some context and gain kind of a richer understanding of the micro and meso mechanisms driving these kind of ascriptive hierarchies that we see in the healthcare sector, we drew on a convenience purposive sample of 19 people of color in the healthcare field to explore their experiences and perceptions with bias in the workplace and the implications for their career pathways overall. And while we did aim for sort of a more representative sample, females, African Americans, and first-gen immigrants made up a large proportion of the sample, which actually uncovered some really interesting intersectional experiences. So, to begin to understand this question, we wanted to know what experiences of bias and discrimination interviewees had encountered in their careers. And when probed, respondents often attributed their experience with bias to their sort of interlocking identities. And this is a pattern that we saw in earlier qualitative studies. And so actually with 10 of the interviews, we piloted a tool that asked respondents to select from a list of social identities and describe how these multiple identities have affected their treatment at work and their career pathways overall. And so while many interviewees described direct experiences of bias, respondents often mentioned sort of vicarious or anecdotal experiences, which is sort of in line with the literature. And moreover, a few of our respondents talked about blatant acts of discrimination. Sorry, not many of our respondents talked about blatant acts of discrimination. Rather, what they really were describing were more subtle forms of bias. And from their comments, we saw that bias was really positioned as this kind of continuous and inevitable feature of their everyday social reality rather than sort of incidental and disconnected events. And from the interviews, we identified sort of two key social relational mechanisms through which kind of inequality is reproduced. So first, we saw evidence of microaggressions. These are subtle or blatant behaviors or comments that result in the estrangement from or invalidation of one's professional identity. So for example, being profiled at work, being overly scrutinized, and being overly kind of subjected to formal disciplinary action. And another mechanism we identified was opportunity hoarding in the direction of in-group favoritism. So many respondents narrated experiences of having an out-group status and consequently being excluded or deprived from career-enhancing social capital resources. And since first-generation immigrants made up a large proportion of the sample, the interviews also revealed some really interesting facets of bias that appear to be emerging with the changing composition of the labor market arising from, increased immigration. So for example, if you see the quote highlighted in red, it kind of shows how immigrant status and racial stereotypes intersect with structural conditions to shape workplace relations. And then similarly, the quote in green comes from a person who described their experiences navigating multiple gender and ethnic-based systems of oppression. And in this quote, she highlights her encounters with gender bias from a group who also occupies a stigmatized status in the labor market. So, overall, what we saw were the themes sort of highlight the effects of bias on workers' empowerment, professional recognition, and access to opportunities.
Okay, time to wrap up.
Okay, so this is my last slide. And from the interviews, we identified kind of ostensible connections of bias with career trajectories in the long term, including negative impacts on performance, being stuck at a certain occupational level for a protracted period of time, becoming demotivated from pursuing career advancement, and exit from jobs or from the career pathway. So I'll wrap up now, but we are, we look forward to engaging with you about policy recommendations and the points you see that are interesting and relevant for further development and inquiry.
Excellent, thank you, Sara. Turning it over now to Yaminette Diaz Linhart and Christine Bishop, and Yaminette will present their work. Thank you, Yaminette.
Yes. Sharing my screen here. Can everybody see the screen?
Yes, indeed.
Great. So hi everyone, my name is Yaminette Diaz Linhart, and I'm a third-year doctoral student at the Heller School at Brandeis. And today I'm going to give you an overview of our pilot case study with frontline healthcare workers in a complex care management program of a Medicaid accountable care organization. It's a lot to say. Dr. Christine Bishop is also part of this work, so I'm going to invite her to wave hello and chime in at any point. So complex care management programs are designed to help patients with complex medical and social needs. These programs aim to improve the health of patients while lowering costs and targeting appropriate healthcare utilization. And all of this is part of a move toward accountable models of care, and those are designed to align payment with care delivery and care outcomes. So workers hired for complex care management programs range anywhere from nurse care managers, social workers, community health workers, patient navigators, care coordinators, kind of these boundary spanner roles. And so previous research on the health and safety of the social service workforce has highlighted high turnover rates and underreporting of occupational hazards. These workers are tasked with coordinating and integrating care for patients across and within multiple organizations, again, at the intersection of both medical and social needs, making these workers kind of a unique and understudied workforce. So our main research questions for this case study were to understand the safety and health issues faced by frontline workers and to understand the organizational factors that contribute to workplace health and safety. We used participatory methods to co-design the research with the frontline workers. We conducted focus groups, qualitative interviews, an anonymous online survey, and field observations to gather descriptive information on the health and safety of the workers, as well as what organizational practices were kind of supporting well-being in their own kind of words. So we operationalized and measured well-being pretty broadly through worker perceptions of stress, satisfaction, and also we looked at organizational support structures as well as kind of validated survey questionnaires. And if you're interested in more of the minutia of the methods, the abstract should be posted that has a little bit more information. So what works for the workers? Complex care management workers voiced that supportive work structures are really key to well-being, and these included care planning meetings, supervision meetings. They had these resiliency groups to debrief the stresses of doing the work. And in this particular care management program, the workers did report on the whole feeling generally supported by their organizations. One thing we heard loud and clear was that workers draw a substantial amount of satisfaction from the actual mission of the work, while also noting the emotional labor of caring for both patients and the organizations they work with, given the demands of the work are very stressful. And since the work itself is very demanding and stressful, the work really should be designed to reduce any duplication of services, burdensome documentation requirements, and then clarifying roles and responsibilities given the nature of interprofessional work. Also, developing structures that actually help and promote coordination is really key to reducing the stress of the workers. So because workers devote such a substantial effort to these system workarounds, they did report feeling like their kind of expertise in that is actually not necessarily really acknowledged. And so I want to actually end with two quotes that summarize a really key takeaway on transparency and inclusivity. And this is really shaping my research on healthcare worker well-being as I move forward into my dissertation work. Some improvements, this is from a community health worker. Some improvements, I'll just say one, and this is high level. When making any decision about any type of program like this, always ask the people at the very, very bottom about how it is that they should go about to do anything, because I find that higher level administration and staff don't have a good picture of the day-to-day, how things are, and just people-to-people interactions. And then from a nurse, our workforce is like 80% women of color, and our leadership team is basically all white people. So there are representation issues, communication issues. How do we build a sense throughout the layers of the organization that the organization is cohesive? Because I think that's related to retention. These quotes illustrate the importance of including the workers in both strategic and day-to-day decision-making processes, especially as it relates to their well-being. So I look forward to discussing how these findings might help build a healthy and sustainable healthcare workforce. I'm going to stop my share. We'll move on to the next presentation.
Thank you, Yaminette. Wonderful work, and thrilled to turn it over now to Olaleye and Lauren Hajjar. Lauren is a graduate of the Heller School, and Wale is a current student there, so keeping up the Brandeis Heller School theme here. And Wale, take it away.
Thanks, Jody. Can you hear me?
Yes, we can.
Okay, awesome. So I would be presenting, I tried to run fast through the presentation, and I co-authored this work with Lauren. So Lauren, please feel free to contribute where necessary. But I hope to cover just a quick overview of the evidence that shows that relational coordination matters for well-being, and then to provide a brief context of our study and the methods, and just describe key findings very quickly. I'll go right into it. So as we all know, relational coordination is defined as a mutually reinforcing process of relating and communicating for the purpose of task integration. And it is most important in situations where tasks are independent, uncertain, and time constrained. And we know that relational coordination theory predicts that relational coordination improves outcomes for multiple stakeholders, including workers and their customers. And worker well-being and relational climate that predicts positive outcomes have been well studied in various settings. In various healthcare settings, relational coordination have been positively associated with so many outcomes such as job satisfaction, work engagement, professional efficiency, motivation, identification, organizational values, and also found to reduce burnout. However, change management strategies to strengthen relational coordination have succeeded in some cases, and in other cases have failed. And so the aim of this study was to determine whether the implementation of relational as well as some structural interventions had a positive impact on worker outcomes such as job satisfaction, engagement, and burnout. And this study was carried out on 3 medical units of a large academic medical center. So just a brief context. Like I said, the study was conducted in an academic medical center in Boston. This organization had in recent years been faced with rising patient acuity and complexity, in addition to some operational efficiency related challenges. As a result, they began implementing a number of structural and relational interventions in alignment with their commitment to quality and safety that involved, and these interventions involved implementing a new rounding structure, some teamwork skills building, and some relational interventions to build RC. And so this study was sort of an evaluation of the change effort at this hospital. The study used a mixed methods cross-sectional pre-post design to study changes in RC and worker outcomes at 2 points in time using the validated RC survey. We also did some qualitative work, which included unstructured interviews and observations to be able to help us explain the findings better. This next slide is just shows the timeline of what happened from April 2017, where they began to implement relational interventions. But prior to this time, as far back as 2005, the organization had been implementing lean intervention problems, a set of problems they considered complicated, but not as much with complex problems. And so we see that the first round of survey was at some point in December and January of 2017, and the second round of surveying where we collected data was in April of 2019 last year. And in between, they had some team working training interventions. They had some intervention for doctors and nurses. And at some point in between those interventions, we performed the qualitative work. So we did some unstructured interviews, and also we also did some observations.
Well, there's less than 1 minute left, I'm sorry to say.
So just quickly into the results. So the results here captures the change in RC, as well as the 3 engagement, satisfaction, and burnout for the 2 times. I've highlighted what I found as our key findings here, which I described on my last slide. So from the quantitative findings, we found a minor improvement in mean RC between work groups, excluding patient care technicians and social workers, where there is a slight decrease in RC. We also found that there was a downward trend in worker outcomes across all 8 work groups from baseline to follow-up survey periods. And these negative changes were statistically significant for between baseline and the follow-up for job satisfaction and worker engagement. From our qualitative studies, we found a few things, some positives, some negatives. We found committed and dedicated employees across work groups. We found strong relational coordination among doctors, but we also found lack of trust between doctors and other work groups. We found inconsistency in shared accountability embedded in culture. We found the variation in meeting structures and attendance. And we found that some groups, like PCTs and even social workers, were excluded from most of the interventions. And I just have this question, at the end to wrap up my presentation. This finding is consistent with a relatively new body of evidence that shows that RC change effort works in some cases and have failed in some other cases. So why was this change effort not successful? That's kind of what we're grappling with right now. And we hope to do some more qualitative work to help us answer that question.
Excellent. Thank you so much, Wale and Lauren, for this work. So I'd like to turn it over to our final presenters. Phoebe is going to present on behalf of her co-authors, Ariel and Harry. Take it away, Phoebe Strom.
Yeah. So diverging from the Heller School monopoly on this session here, adding a little diversity to the room. So what we were interested in is clinical integration, and there's this increasing focus in healthcare, as I think many of the presenters have alluded to already today, on integrating care. So integrating care across facilities, across providers, across different occupations, and throughout the care process. So following the patient through the care process. And this has been linked to all kinds of great outcomes for patient care and for organizational effectiveness. So improved information flow, enhanced organizational learning, increased efficiency, better outcomes for population health, and the list kind of goes on and on. But what we don't know as much about, and there is some great work, mainly from Jody, what we don't know as much about is how this affects the actual workers doing the integrating. So we have some positive findings for relational coordination and for teamwork that suggest that this can improve job satisfaction, reduce burnout, and improve worker morale. But we also see that a lot of these clinical integration efforts are associated with widespread dissatisfaction. There's a lot of employee resistance, there's a lot of backlash, and a lot of these efforts are failing because of this employee backlash. And so this presents a puzzle in terms of, if this is so good for workers, if they do appreciate this so much, why is this consistently why isn't there more of a consistent link between that and all of these implementation efforts? And so this is important for 2 reasons. I mean, it's important, one, because healthcare workers are a massive sector of the workforce, and if they're suffering because of the type of work they're doing, that's a problem in and of itself. But it's also important because of the link between worker well-being and patient care. So these efforts can't succeed if workers are burnt out and not committed or engaged to with their work. And so what we suggest is that what really explains this puzzle, or potentially explains this puzzle, is that there are different types of clinical integration efforts, and that facilities often implement bundles of them at the same time. And there's some evidence that shows, looking at patient outcomes, that shows that they can have divergent effects. And we suggest that there's something similar happening in terms of employee outcomes. So we highlight 3 types. The first bucket is interpersonal integration, and this would be where teamwork, relational coordination, multidisciplinary teams would fall. And we highlight that it's important to consider integration within your focal unit, so the people you're comfortable with, work with on a daily basis, and integration with providers in other areas. And then we also highlight process integration. And so this is integration throughout the care process and focused on kind of specific clinical practices to aid the integrated integration. So this would be referral guidelines about patient intake, follow-up, things of that nature that aren't explicitly geared to integrating with other providers, but following the patient. We just want to highlight some findings here. So we did this in a district in New York that was under the Delivery System Reform Incentive Payment Program and was shifting to integrated care. We have a survey of 758 frontline workers and interviews with 56 frontline workers. And so what you see here is that within unit integration is really highly associated with improvements in worker well-being. And we suggest this is where a lot of the initial teamwork and relational coordination positive findings are coming from. That when you work better with your close team, it really improves your support system, it really improves your experiences of work. We also find positive effects for process integration. So, this is streamlining clinical processes, sharing information. This seems to improve workers' experiences. But where we're seeing some declines is integrating across units. And so we suggest that this is a place where facilities need to consider more carefully how they are putting these practices into place. And I'm not going to go into it right now because there's a lot there, but I hope we can come to it in the discussion. We highlight in our interviews some ways that facilities can do this in terms of thinking about the structures into which they implement the integration efforts and how to build those structures in such a way that the between unit integration efforts don't increase employee workload, don't result in negative work interactions, don't make employees feel devalued. And so how do you do that? And we suggest that it's organizational messaging aligned with key organizational practices. And so that's what's highlighted here at the bottom. So thank you.
Literally, my timer just went off as you said your last word. So somebody was working on the timing there. Well done.
I tend to be very precise at timing. It's years of speech and debate.
Oh, yeah, that's a real skill. I gotta work on that. So so thank you. That was a Cornell dominant team, and it was, so thank you for breaking up and giving us a little diversity in our presenters. And now we turn it over to our discussants. Thrilled to have Sara Chaganti, who is a recent graduate of the Heller School Brandeis, not so recent, but she's, we're very pleased to have Sara, and then John August, who's with Cornell University. And I don't know who wants to go first, but it'd be wonderful to have either of you kick off our discussion.
Either way is fine. I think I'm first on the program, so
Let's hear from Sara.
I guess I'll go for it. Hi, everyone. Yeah, back to the Heller monopoly. It's nice to see some old friends. So thanks, everyone. These were really interesting and great papers. And I was glad to see the Sara and Jess's paper first, partly because it builds on some work I did, but more importantly, because I think it framed the discussion nicely. So the first paper examines the mechanisms that drive occupational segregation by race and gender in the healthcare industry. And they find racialized, more so I think than gendered, structures that limit career mobility for workers of color. And I mean, the healthcare workforce is largely female, so race, it makes sense as what would emerge. So that got me thinking that presumably integration between groups, and especially vertically, is important, and is as important as integration within each segment. So if we know that communication strategies within teams are so effective, then is there a way to build on that to break down these racial barriers to improve career mobility for workers of color? And actually, I think someone else asked the same question in the chat box. So I wonder if there's a way to use relational coordination explicitly to create career pathways, or is there a parallel strategy that should be going on at the same time that addresses occupational segregation? The next three papers look at the question of that integration between groups and especially vertically. And I think all find this challenge of between group integration. So I guess my question to all three authors is, what role does each group's racial makeup and attitude toward diversity and inclusion play in this challenge? The first paper looks at a context in which integration is particularly important and focuses on these sort of boundary spanning occupations, which is quite interesting. And they find that these workers experience significant stress, which could be a function of the requirement to work across units. And I do wonder if some of the stress might be a product of having to operate across racial groups. And one of those, Yaminette's final quote actually suggests this. So I wonder if there's more there. They use several validated instruments that test stress, and I'm assuming don't ask anything about the stress of being, of racial tension in particular. But it would be great if the qualitative data could yield patterns that could use to be developed, a survey that's specifically about that. The next paper looks at an intervention, a relational coordination intervention in a healthcare setting. And again, they find that relational coordination improves worker well-being, which is great and consistent with what we would predict. And within group, it's pretty easy to achieve. Between groups, it's harder. And again, I wonder if there's something about the racial makeup of groups and I think the finding about PCTs in particular might point to that. That's an occupation that tends to be women of color, and there's a clear power dynamic there that's related to race. And the last paper I thought does a really nice job of quantitatively isolating that between group integration as the key challenge, separating it out from the within group integration and process integration using survey data. I know race is included as a variable. I wonder if there's a measure of racial homogeneity in the also that, and if that could be tested for correlation with the groups. And couldn't tell if race showed up as significant, but if it didn't, that might be why. And that might tell you something. So I guess the main point that I want to make is that a race-neutral theory and analysis might not be able to give us the full picture of what's affecting worker well-being, because clearly we live in a world that is not race-neutral, but also the healthcare workforce in particularly is definitely not race-neutral. And so race is very salient to people's experience working in the sector. That's it. Thanks.
Thank you, Sara. Some excellent things to discuss in the next, in our open discussion. And so let's turn it over to John August, and looking forward to hearing your thoughts on what we learned this afternoon.
Thanks, Jody. Well, I really appreciate the research and the scholarship and the direction that all of you have taken, because I think we'd all agree that the movement to improve healthcare across the United States in terms of improving the health of the population, improving the experience of everyone who requires care, paying attention to social determinants of health, as well as reducing cost so that healthcare can be affordable in this country. So this, what I would call this improvement journey in healthcare, has been underway for a long time. My observation is that not unlike the fact that we don't really have a healthcare system in this country, a lot of the efforts at improvement remain disaggregated. And as a result, I think many of the dynamics that you identify are dynamics that become, fully exposed, because I think there tends to be more of an enterprise approach to outcomes. There tends to be an enterprise pressure on metrics that people don't necessarily own. And as a result, all of those things, I think, tend to really exacerbate a lot of the tensions that you're describing that really do negatively impact workers. This is a dilemma that I think we'd all agree is probably getting worse than better. And so thanks to your scholarship for pointing these out in new ways. I'll just conclude by sharing that I think that there has been some great practical work done. I would also argue that where workers are unionized, especially in large systems, I think it's very important to understand that the ability to kind of make some equilibrium in the power relationship is ultimately very important. And until and unless that is addressed, I think that a lot of the issues will remain raw and become more raw. I think that when I say unionized, I also think that that means that unions need to take on a very, very important role in how that power is actually shared. And I'll just summarize by saying that I think that we've learned that there's probably 6, I think, important elements of how power sharing and power intentionality can create the right environment for workers to be able to be highly engaged as well as feeling a sense of security. I think that number one, leadership has to evolve to becoming more of a coaching style of leadership as opposed to a hierarchical and demanding kind of leadership. Secondly, there needs to be serious line of sight between what workers do every day and enterprise outcomes, that they really need to own the outcomes and the metrics. Third, really paying attention to the nature of teams. We're asking people to work in teams, but really are they teams? We need to pay attention to whether or not there is cohesiveness there or not. Fourth, people need to be working in processes and methods that they own and understand, not something that is just imposed off the shelf and handed to people. There needs to be a continuous kind of training and sponsorship. And perhaps most importantly, we have to pay attention to our dear friend Amy Edmondson's call for continuous psychological safety, and that ultimately what we want is to create an opportunity for the institutions to be learning organizations as opposed to only outcome-oriented organizations. So that's my perspective on the practice of the evolution, I think, of organizational change. But again, I think that the work that you're doing, keep doing it, because we need to hear more and more about the actual impact on workers as we begin to have the organizational change implemented. So thanks.
Thank you. Perfect timing from John as well. Thank you. And some really interesting thoughts about the power gradient. And one thing I've noticed in the research is it's not just between the leaders and the workers, but the power differential between work groups has a negative impact on things like relational coordination and worker well-being. You tend to see the higher power role reporting high RC and the lower power role saying, well, not so much for me, even in that same work relationship. So this is great food for thought. I'd love to ask Abigail Sherborne, who's here, also from Brandeis, a Heller MBA student, to just sum up what you see in the chat box, and then we'll open it up for, first of all, to hear from our panelists and then everybody else.
Sure. So the first question that came in from Andrew was to Yaminette and Christine. So what types of voice mechanisms for frontline staff exist in this org, and are any of them more effective than others? Being the first question.
You can just maybe go through all of them and then we'll open up.
Oh, absolutely. Sure. Then the other, another one that came in, do you find that healthcare caregivers have more positive employee incomes when they are positively recognized for their work, such as monetary awards or certificates? Another one, in what ways could the conflict resolution community be helpful in reducing the communication difficulties between the various levels of the workforce and improving the promotional opportunities for workers of color? Those are the three that came in addition to Sara and John's comments.
Great. So let's take all those comments together and maybe hear a minute or two from each presenter on your initial and responding to any of those points that you want, and then let's open it up more broadly. So let's go back and start with Sara. And Jessica is welcome to jump in here too.
Well, I don't know, Jess, are you, I thought it, so I can maybe kind of speak to that question. I mean, I think we need some, part of what our motivation here with this research is, like I said, we're interested in sort of translating these findings into sort of evidence-based workforce development strategies and interventions. And so what we're hoping to do is to draw on these interview findings and the literature and think about developing a conceptual framework that can assist researchers and practitioners in thinking about how to include an intersectional or consider sort of the intersectional lens when they're designing workforce development programs or strategies internally. So I think, you know, that's sort of our starting point, and that's actually, to Sandra's question, that's really sort of what's motivating our research, is that we feel there is that gap in sort of integrating like Sara Chaganti mentioned, it's a lot of the workforce development sort of kind of programming and interventions we see have this sort of a race neutral kind of perspective. And what we want to do is introduce that into the conversation and think about how do you design career pathway programs that take into account that, you know, this is a very diverse workforce. It's highly segmented. Race, gender plays, you know, they play a significant sort of role in segmenting the labor market. So, you know, and then there's these sort of workplace relations that reinforce that kind of segmentation and create barriers for mobility. So these are things that I think we need to, we're hoping to use this research to kind of build on that platform of developing more of a discourse around intersectionality and sort of promotional pathways.
Great. Really appreciate your focus and the focus of others on, oh yeah, Christine, please.
Oh, I just wanted to ask, it seems to me that the health workforce is so incredibly credential bound. This is very important insight to understand at this level, the intersectionality, the role of race and gender, but the credential bound nature of it is such an overriding force to keep the occupation segmented. And I'm having trouble putting those two things together in a way to move forward.
Yeah, it's interesting. There was a session yesterday showing that in a certain field, I think it was tax returns, credentials help to increase equity, especially at the higher end of the quality spectrum, because it was an objective measure that maybe got around some bias, but I can see it working in the other way as well as an exclusionary device. So let's definitely keep that on the table. Love to hear from Yaminette. Any reflections you have on what you've been hearing?
Yeah, so I think this issue of worker voice, so one of the things we learned was that because of the new accountable care organization structure, just the legal structure of it, that the workers were employed by the ACO, so they had mostly standard work arrangements like full-time, some salaried, some hourly kind of work arrangements, but they didn't live in the ACO because the ACO is a legal structure of lots of different organizations. So then they were deployed into different sites and different organizations. So many of them were part of the unions, just as part of the kind of local, the same way that you would hire a nurse or a community health worker in that health system. But because they were deployed into the sites, then they really didn't have much of a say. There really isn't that much kind of, there aren't mechanisms for worker voice based on just how the work is structured. So I think we were really fascinated with this kind of very bizarre and also interesting way to employ and organize these workers. So they're in sites doing patient care out in the field, but the sites that they're in, they're not employees of those sites. So the supervision piece became very, very key to actually helping them have really basic things like access to printers and access to Wi-Fi just to do their work. So I think it's definitely an area that's underexplored in the way that the ACO kind of work is structured based on what it just looks like practically. And it's such an emerging and new kind of way to structure work. So I think this issue of the racialized nature of the work is also there. And our surveys had some questions on if workers ever felt discriminated against, but nothing that was kind of outright kind of targeting their own personal experience. Although, you know, you saw the quote that was there. I think this was a sentiment with a lot of the workers that they just felt a little bit invisible and they weren't necessarily appreciated or acknowledged. And it's also even more important for workers who really identify with the work. So if you're doing work that you really identify with, then what does that mean if your employer does not really acknowledge or validate that?
Mm-hmm.
Especially since the community health workers are chosen for their attachment, their membership in these communities. It's sort of a fascinating aspect of this.
Yeah, indeed. Wale, just curious whether, if you want to build on that at all.
I wanted to ask if Lauren wanted to say something.
Sure, I'm happy to jump in, Wale.
Okay.
Yes, so in addition to, I want to make 2 points. One is that in addition to race and issues around power between doctors, for instance, and patient care technicians, there's a social class issue that is furthering this pay and power differential. The second thing I want to say is in response to Sandra's question in the chat box, I think that the conflict resolution community could be very helpful in helping to facilitate, for instance, conversations of interdependency between these different work groups. So we measured RC, but the reality is that in this organization, they were not explicitly ever building relational coordination as part of the intervention. So they did things like they had a mentoring program and a buddies program, but they weren't explicitly having these conversations of interdependency to say, what is it about, you know, your job what can I do to help you in your job? And what is, you know, what is, when you come to work and you do your job well, what is it about that? What are the conditions under which you're doing your job well? They're not really engaging in these kinds of conversations that I think could be helpful. The other piece I think that's critical, and there's a lot of room for growth here, is training around facilitation skills for docs. And we observed in these huddles something very interesting, which was there was a lot of variation with which doctors were able to facilitate these patient care plan huddles. And some did it fairly well, and some were able to bring in the voice of every one of the stakeholder groups. Others just didn't, and they're not trained to do this. So I think there's a lot to be learned, for instance, from countries in Scandinavia, where they actually have the nurses that are facilitating these huddles, and that really helps to offset that power dynamic between the docs and nurses, at least. So, but Wale, feel free to add to that.
Yeah, I was just going to add that, speak a little bit about the direction in which some of our work is going due to the findings we have. We're beginning to think about role hierarchies, and like Lauren mentioned, the socioeconomic differences between roles and how that creates hierarchies within care teams. And we're trying to see if this hierarchies actually impacts the experience of workers as it relates to just relational interventions and also their well-being as workers. So that's the direction that we're looking to go with some of the findings that we have. And also just thinking about why relational interventions that are supposed to build on RC and also worker well-being works in some settings and doesn't work in other settings. Just comparing results between what we find in, say, like another academic medical center, what they've done and what worked, and why it just didn't work in this situation is something we're also looking at exploring.
Yeah. And I'm kind of curious whether that would have been the training of people to facilitate those interdisciplinary rounds, maybe at the University of Washington and maybe not at the other place. That could help to explain, as Lauren's pointing out, there's a major skill set involved there. Would love now to turn it back to Phoebe and find out, yeah, how would you respond to what you've been hearing?
Yeah, so I really wanted to talk about Sara's kind of call to put race into this, because it's something that I think is really important. It's something I was actually really surprised was not significant in our survey results, either as a main effect on well-being or as an interaction. I think, you know, it does come up in our qualitative results. So there's a number of places I wanted to point out. So we have some mechanisms we identify linking these interventions with worker well-being. And one of them is proximal work interactions. So the interactions with your immediate coworkers as well as patients. And a lot of what we were hearing about race was really related to how patients interacted with providers who were non-white. And it was tended to be pretty negative. So I think that's something that has not come up in this conversation. We've been talking about racial interactions between healthcare professionals, but there's also this provider-patient dynamic. And I think there's also an issue of employee identity. So one of the things that was made kind of these interventions positive or negative for employees was whether they felt valued and, you know, treated as a professional. And obviously the people of color in our sample reported feeling that less. And so there's definitely stuff coming up in the qualitative findings, also in terms of who has discretion, who is given the option of kind of making these choices. And the final thing that I wanted to talk about maybe with that, it's not race as much as kind of immigration status and ethnicity, but we also had a significant proportion, particularly of CNAs who were Spanish speaking primarily. And one of the things that was shocking to me was the degree to which they did not have the same quality of training because materials were not provided to them in Spanish. And so they didn't understand the initiatives as much. And understanding the initiatives was really important for employees kind of getting on board. If they understood why they were doing it and why it was important to care, they were much more likely to report that it was a good thing and that they were committed to it. And so it seems like there are some simple things, some simple moments where we could lessen those divides. Just briefly, I also wanted to talk about the rewards question. We didn't have anything about rewards per se, but we did have findings for kind of financial related issues in terms of a lot of employees did feel really devalued when they were being kept under the cap to be part-time, or they weren't getting their time off. So those are kind of financial incentives per se. So I can't speak directly to financial rewards, but maybe not penalizing employees financially does seem like it certainly improves their well-being. So.
Thank you, Phoebe. And with that, I'd love to open it up to the rest of our participants. Anything you want to ask or share from your own experience?
Jody, while people are asking questions, if I can, I just wanted to comment on the voice and conflict question real quick, if that's okay.
Sure, Ariel.
So just really great questions on voice and conflict. And the thought I had sort of combining those two together in the relationship to our paper is I think we often, both in the scholarly community and in the practitioner community, we assume that integration will increase voice and decrease conflict. And I'm not sure those are assumptions that we can take for granted. Our finding about sort of decreased employee outcomes for integration across units suggests that there's possibly sort of an increase in conflict and not sufficient. We don't measure this in this study, but it's possible that voice might help to explain some of these findings. I know, Jody, that in relational coordination, you look at conflict resolution specifically, but I think there's a lot more that we could do to link conflict to these types of studies on integration, relational coordination. I'll just say, I just want to echo Lauren's comment about competencies for healthcare professionals. In my own work, I've seen a real lack of competency in dealing with addressing conflict, even minimal or basic issues in the workplace. I know that we know that there's an increase in conflict management practices like the ombuds function in place to try and deal with these issues, but this is an area that's ripe for additional research.
Yeah, it does seem like some of the early work on conflict, it recognizes that when you bring people together across difference to work together in a way they haven't before, you can expect conflict, but it could be constructive if it's well facilitated. So that's really excellent. Yeah, please feel free to just jump in now. I'm looking at Janet Napple and Eileen Applebaum and Janet Wilder, just because I know they've worked in this space, but they're really welcome any voices here. Do I have to cold call?
Can I respond to a question in the chat, Jody?
Yeah, I see you've got one there from Zach. Is that what you're looking at?
Yeah. So our data was over multiple facilities, and we did control for that. But it does seem to hold across the facilities. We split off the hospitals and the nursing homes. And the effect shows up everywhere. What's interesting is he's absolutely right. Nobody likes the silos, but they also, when they report that the silos are breaking down, it also seems to produce these new tensions. And so I think it is an inherently more challenging process to engineer and to make effective, for sure.
Yeah. Goodness. Sandra, any other, not everyone has their camera on, so it's hard to cold call someone who doesn't have their camera on, but Sandra and or Ariel.
Jody, I know that usually it's the discussant who asks us questions, but I wanted to ask John a question in the context of Dennis's remarks, presidential address just now. You talked about the role that unions play, but John, can you say a few words about labor management partnership and how it might enhance efforts for integration, and then some of the other issues that we talked about during this session?
And thank you for inviting me to say something. I'm going to be the new chair of this group, I understand. This is the Diversity and Inclusion Group. Is that correct?
I'm not sure. I think this was one of the healthcare presentations, but we're certainly, getting into that domain.
Oh,
yeah. So
okay.
Really glad to have you here, and congratulations.
Well, thank you. I thought I was joining the group of diversity and inclusion providers, and that's why I was a little bit confused that it seemed to be focused on healthcare, but I thought, well, that was good they chose that particular topic. But at any rate, so certainly the subjects that you would have discussed and the documentation and research that you have done certainly provided me with a good vision of the problems that do exist with regard to diversity and inclusion. And particularly, I appreciated the comment that they can be related in some fashion to the criteria certain requirements, simply because they only fulfill requirements. People of minorities may only be able to get the education necessary to qualify for positions at lower levels in this particular workplace setting. Mm-hmm. The higher you go, the more medical training and certification you require, and that costs a lot of money. So I think that, there are certainly issues that are not easy to resolve through just communication. But certainly I think that the dispute resolution providers that are members of LIRA will be looking at ways that we can be instrumental in trying to eliminate the stratification or the system that exists, which seems to require the lower levels to be filled with persons of color, and that we need to try to eliminate that and see the ability to improve the status of people that need to achieve better incomes and more power and importance in our communities, so that we don't encourage the white privilege that it kind of exists at this time. So that's kind of going to be my mission in this position for the coming year, is to try find ways that the dispute resolution professionals may be helpful in working with the business communities to find ways to improve the status and recognition of persons of color.
Sure. I would love to just recommend on that note a paper that was presented last year at the LIRA meetings. I think it was last year, maybe 2 years ago. It was Baltimore. Jessica and Sara presented on interrupted job ladders and the inability for people, unless they have outside sources of either financial or social capital, to get to the next level of that job ladder, because it's not built in. It's very hard to move, for example, from a CNA to an LPN, let alone to an RN. And so there's a gap there in the larger environment that where the credentialing does become a barrier to moving people across the job ladder. And I feel regretful that John August was not able to respond to Ariel's question regarding the equity issues and whether the labor management partnership can help to address those. But if you want to speak for a moment on that, it would be lovely. And I know we have another session coming up on this line, but if you have a moment, please go ahead. Oh, you're on mute, John. On mute? Yeah, thank you.
All right, so we'll take the most complex question we can think of and talk about it for a second. What I would say is this, just briefly, and thanks to everybody for this session. I think that the evolution that must take place in labor management relations, and I say must, is because we have to find a way of sharing both purpose and power with, in this case, the healthcare industry. We have to find a way of sharing those things so that we can build change on mutual interests. And I think that the equity questions here that have been raised, the many variations and just broad list of challenges that have been raised here, I think can be solved in the context of involving teams at the front line through problem solving, because the problem solving, I think, is what drives the environment for the solution to these other issues. You're not going to be able to solve a problem of, patient care or cost or outcome, unless you really do have cohesion in the workforce. And so I think cohesion in the workforce is central, to what labor management partnership is, as well as the broader question of purpose. What is our purpose in labor relations in these times? And I would say it's the largest room we have is room for improvement. And it's not going to happen unless the workforce is really directly engaged, not only for their contribution, but to see to it that they are full members of every team that they're a part of. And that includes race, it includes income, it includes these very, very troubling issues. But I think that they can get resolved in the context of a broad understanding of why we must change. So.
Yeah. Well, thank you for those concluding remarks, and thank you to all of our panelists. I think it was a fabulous session. So a round of applause for them, and also for our our participants and for asking your wonderful questions. And feel free to stay. We're now talking about some kind of similar issues of building collaboration in the public schools and in graduate education. So take care and enjoy the conference.
Thanks for organizing the session, Jody. Thanks for
Oh, and
facilitating.
Ariel, yes, was my co-organizer. So please, same to you. It was lovely to do it with you. Thank you, Ariel.
No, you're welcome. Thank you.
Thank you so much, Jody.
Yes, thank you, Sara. That was great. Good to see you.